Well, this is certainly not the way we expected our team to be covering ACC 2020 with the World Congress of Cardiology scientific sessions, but not much of what's occurred in the last couple of weeks has been expected, let alone precedented. Still, as fortunate as we are to have healthcare leaders and workers combating the spread of the coronavirus in our country right now, we're also fortunate to have the technological capability and drive to continue the spirit of medical meetings like ACC with or without a meeting space. The meeting will go on virtually, and so will ACP Live's coverage. So welcome to our first interview in our special edition House Call series. I'm Kevin Kunzman, Managing Editor of ACP Live, and I'm happy to be joined today by Dr. Gilbert Tang, Associate Professor of Cardiovascular Surgery at the Icahn School of Medicine at Mount Sinai and Surgical Director of the Structural Heart Program for the Mount Sinai Health System. Dr. Tang, thank you so much for joining us today, and how are you doing?
Well, my pleasure, and thank you for having me. Certainly, these are trying times, and I think kudos to all the healthcare frontline workers out there combating this pandemic.
Absolutely. It's just remarkable that the kind of work everyone, you and your colleagues, are doing around the clock, and on top of that, making time to still discuss the trends in and out of this pandemic with the community and with the media. It's really commendable work, and someday when this is all resolved or we're feeling a little more optimistic about it, we should take time to congratulate that a bit more. But for now, let's talk a little bit about ACC. You actually had some data prepared to be presented. It's probably around this time next week, right? But with the meeting being canceled for obvious reasons, we can talk about it right now. So the ALIGN-TAVR findings. Obviously, TAVR has been a huge discussion point when we're talking about some of the most advanced practices in cardiology of the last decade. We're at a point, it seems now, where we're talking about refinement of the practice and what it can mean for some of the most critical cardiovascular risk patients. So, Dr. Tang, if you want to start off by giving us a bit of, if you want to brief us on the abstract of exactly what was, the findings from ALIGN-TAVR.
Yeah, no, first of all, thank you very much for ACC and Jack for allowing these publications to come out in a very expeditious manner and to be able to communicate to the cardiology and greater community some of the research findings. Really just very impressive at how they're able to manage to convert the entire in-person meeting to a virtual platform. So thank you very much for that. Study actually has already just published online in JACC Interventions earlier in the week. So again, thank you ACC and JACC Interventions for doing that. So in essence, let me just summarize the current status with TAVR. As we know, TAVR is already approved in patients with symptomatic severe aortic stenosis across all surgical risks by the FDA. So there's essentially no delineation of which risk patients have in order to be considered for TAVR. Most of us now are trying to optimize the TAVR techniques to be able to reduce some of the limitations still associated with the current technology. So, for example, pacemaker, left bundle branch block, paravalvular leak. And now we're talking more about these patients who are getting younger, getting TAVR, may have coronary artery disease that are not need to be treated right now, but may progress down the road in the future that might require diagnostic or even therapeutic intervention. In addition, we all know, even from the surgical valve literature, that there's prosthetic valves, these are tissue valves that TAVR valves are made of, do not last forever. So as we have patients who are younger getting TAVR, the next question we have is, if these TAVR valves fail and runs its course of time, can we do it again without open surgery? Can we put another TAVR valve inside these TAVR valves? So those are the two things that we are exploring, and this is what this study is about. So the ALIGN-TAVR study is to look at when we implant these TAVR valves, do we achieve the same kind of orientation that we do with surgical valves? So I'm a cardiac surgeon. So when we do surgical aortic valve replacement, we take out the valve leaflets and we implant the valve directly by sewing it in. And we orient the valve commissures like what nature has designed our aortic valve to do, so that we don't obstruct the coronary arteries. And that's why when these surgical valves fail, we now do valve-in-valve TAVR with a TAVR valve inside the surgical valve pretty easily. It's a very safe procedure. Most people go home the next day. But we now know from multiple papers, including ours, that when we put a TAVR valve in, the orientation is essentially random. So when the delivery catheter delivers the valve, at least with the current FDA-approved devices and some of the devices that are used also in Europe, that there's no way to consistently align the commissures or orient the TAVR valve in a similar manner as a surgical valve. And so this is what we're studying with three devices. So the Edwards SAPIEN 3, the Medtronic Evolut, and the Symetis, so Boston Scientific Accurate Neo valve, which is CE marked in Europe already. So we have 5 centers, 4 in the United States and 1 in Europe, collaborating on this study.
That's great, and it's surprising to me in just the few years that we've begun to really expand our assessment of the TAVR devices, that we now are at a spot where it's similar to some of these very successful drug agents we've seen in cardiovascular disease, where we have competitors, we have agents with different benefits, different safety results, different capabilities in terms of long-term efficacy. It seems like the biggest stress for TAVR use, and again, the credence of the study being that duration is critical in these patients. Is that true?
Yeah. So now, as TAVR being expanded, as I mentioned, to younger patients, we need to talk about durability. The durability data right now has been studied mostly on patients who are older.
Yeah.
For example, in the earlier trials. And we have some data on also some of the low-risk patients as well. But the data is still a little bit limited. I think some of the single-center series or multi-centers may be up to 8 to 10 years durability with very, very good result. But we still don't know about 10, 15, or even 20-year result, which will take some time. But I think because TAVR is now the preferred therapy to treat aortic stenosis, in the current era, we need to study more to understand what we can do better. The chapter has not been written yet for TAVR. There's still a lot more to learn, and that's what we're trying to learn in our study.
And can you talk a little bit more about the findings and what sort of implication it has for this patient population? Anything positive? Does this mean that we can expand our patient population to younger patients, or is this a strictly case by case where you got to be hitting some certain metric in order to be eligible for it?
Well, the rationale for our study is to be able to advise our patient when they come to a clinic, particularly younger patients, low-risk patients, that if you get a TAVR valve now, what is the possibility of having issues with coronary access or reintervention afterwards? What we found is that we have 3 different devices, and we looked at, can we control the orientation at the time of deployment, similar to what we can get the surgical valve results. So we looked at more than 800 patients altogether across 5 centers. And we looked at the SAPIEN 3 valve, and what we try to do is to prepare the valve. So for the SAPIEN 3 valve, you have to crimp the valve down to and previously no one really paid attention to the orientation. And now what we try to do is to do that by crimping the valve at either 3, 6, 9, or 12 o'clock orientation right to the catheter, and deliver the valve in a standard manner. And what we found is that essentially the pattern of the final orientation remains random. So about a third of the time, the commissure ends in a certain way. So there are 3 commissures of the valve. So really, there's no predictable way to make it significantly, consistently better with any specific orientation. Now, the SAPIEN valve is one of the shortest frame valve in the market right now. So the coronary access is less of an issue because there's usually room to go above or across the frame to engage the coronary. But when we talked about redo TAVR, or when this SAPIEN 3 valve failed, can we do it again? If the valve frame and the leaflet extends above the sinotubular junction, where the structure is above the coronary arteries, there can still be coronary obstruction risk present. So before we say that, to tell our patients that, oh yeah, we can do another TAVR down the road, that's what we need to study. And so the orientation of the SAPIEN 3 may be important in this regard. So that's the SAPIEN 3 valve. With the Evolut valve, what we found is that the Evolut valve is mounted in a very specific manner relative to the delivery catheter. And on the under X-ray fluoroscopy, we can see the orientation of the delivery catheter when we deploy the valve. And what we find is that when we insert the delivery catheter in a very specific manner with the flush port of the delivery catheter at 3 o'clock, we actually improve the valve orientation of the evolute valve to have better alignment. Now, it's not perfect. Remember, these delivery catheters and manufacturers have not designed a device specific to achieve commissural alignment, but certainly the data in our study suggests that it's better than putting the flush port at 12 o'clock, where the distribution of the commissural alignment is not as good as 3 o'clock. Now, why is it important with the evolute valve? The evolute valve has a taller frame design, and it's a supraannular valve. So the leaflets are mounted a little bit higher up than, let's say, the SAPIEN 3 valve. So people have anecdotally found coronary access after the evolute valve a little bit more challenging, even though the data has not shown to be the case. But if we can improve the commissural alignment for these patients, similar to a surgical valve-like orientation, we can tell the operators that these orientations will be more favorable potentially for coronary access. And there are a number of actually papers published also in JACC intervention on this particular issue, most recently with post-CT data and other data to support this potential hypothesis. The reason why we bring this attention to the community is that, as we know, there are about 700 to 800 TAVR sites in the country, but there are a lot more interventional cath labs in the country who do not do TAVR. And if the patients with a previous TAVR device present to one of these cath labs for diagnostic or percutaneous intervention, we would like to raise their awareness to let them be more aware that the certain TAVR orientation may help them with their coronary intervention or diagnostic results. And finally, with the ACRIT valve, which is not currently available in the US, but is currently in the clinical trial, this valve has a much lower stent frame profile, so it's very easy to get back to coronary access. However, the leaflets are quite tall. They usually extend above the center of the tubular junction, so the redo TAVR may be an issue. And we have not started systematically trying to control the orientation. We've just simply put it in based on the manufacturer recommendations. And what we found is that the distribution of the initial orientation can impact on the ability of the commissural alignment and possible re-intervention down the road. So this is still early finding, hypothesis generating, but we are now trying to bring the attention to the TAVR operators and, more importantly, valve manufacturers to now is the time to come up with devices or delivery system that can mimic a surgical-like result with commissural alignment and valve orientation to perhaps prepare these younger patients who are undergoing TAVR now, that they may have a better shot and possibly doing TAVR again in the future without open surgery.
Wow. So, I mean, beyond the long-term safety and efficacy benefits that we can see from this in patients, this is hugely cost efficient if this is something that, is responded to with change in practice, right?
Yeah, I mean, I think what we try to say is that we want to make patients who now have TAVR devices be able to have a lifetime management option, rather than saying that, okay, we do a TAVR valve now, we'll worry about it later. Imagine a 70-year-old healthy patient come in with very good anatomy for TAVR and got one, and then 10, 15 years later, let's say the valve degenerate, and have to be told that, I'm sorry, the anatomy is no good, we don't have an option now, you have to have surgery, which may still be happening. And that's what we're trying to tell our patients right now. We don't have a crystal ball to predict the durability and what options there are in the future. But based on your anatomy right now, if you get a TAVR, we may not know whether you need surgery or not down the road. And we like to say that for younger patients, they may need one surgery in their lifetime, hopefully not two. But again, we need to study this more, and this is more like a call to arms for the manufacturer to think through this issue very thoughtfully, because as operators, we are limited by what we can do from a technical standpoint, because the device and the delivery systems themselves are limited.